So we are starting on examination of respiratory system. So let's start this topic by studying the examining anatomy of respiratory system. As we know that the right side of the lung consists of three lobes, the upper lobe, middle lobe and the lower lobe. And the left side of the lung consists of only two lobes, the upper lobe and the lower lobe. So there are two fissures dividing the upper lobe, middle lobe and lower lobe of the right side of the lung. These are oblique fissures and horizontal fissures. And the left side it only have oblique fissure. So how do we demarcate these fissures of the lung and divide the upper lobe, lower lobe and middle lobe of the right side and left side of the lung? So let us see. So the right side of the lung has upper lobe, middle lobe and lower lobe, and left side of the lung consists of just upper lobe and lower lobe. So let us see the examining anatomy of the lung, and then we will go into the examination of the respiratory system. So how do we start demarcating the different fissures of the lung? As I told you that the right side consists of two fissures, that is the oblique fissures and the horizontal fissure. Oblique fissures and the horizontal fissure. So how we start demarcating the oblique fissures of the lung? We start from the T2 vertebra, the spinous process of the T2 vertebra. As we know that the most prominent cervical spine while palpating in the cervical region is the C7, the spinous process of C7 vertebra. And after that the thoracic vertebra starts T1 and T2. So we start demarcating from the T2 spinous process. We start drawing a line from the T2 spinous process along the medial aspect of the scapula. As we know that scapula is somewhere here, so along the medial aspect of the scapula, we start drawing a line towards the mid-axillary line, and we reach the mid-axillary line at fifth rib. We reach the mid-axillary line at fifth rib. You can see here we have started drawing a line from the T2 vertebra, spinous process of T2 vertebra, and we have reached this mid-axillary line at fifth rib. We have reached the mid-axillary line at fifth rib. Along the mid-axillary line we are reaching at fifth rib. Then we will continue anteriorly towards the mid-clavicular line, to reach the sixth rib. So this is the oblique fissure. This is the oblique fissure of the right side of the lung. So we have started from T2 vertebra. We have started posteriorly from T2 vertebra. We have drawn a line along the medial aspect of the scapula to reach the mid-axillary line at the fifth rib. Then we have continued this line anteriorly towards the mid-clavicular line at sixth rib. So from T2 we have continued in the mid-axillary line at fifth rib, then anteriorly towards the sixth rib in mid-clavicular line. So this is the oblique fissure of the lung. Then what is the horizontal fissure of the lung? Horizontal fissure of the lung is drawn anteriorly. We start drawing the horizontal fissure of the lung anteriorly from the fourth rib at the right side of the sternum. We start drawing this line towards the mid-axillary line to reach the fifth rib in mid-axillary line. So there are two fissures, the oblique fissure and the horizontal fissure. Oblique fissure is drawn from C7, from T2. We start demarcating the ribs from C7 as because C7 is the most prominent rib posteriorly, so we can easily identify the C7 spinous process of C7 vertebra, and below the C7 is the T1, and below the T1 is the T2 vertebra. So we start demarcating from T2 vertebra through the medial aspect of the scapula to reach the mid-axillary line at fifth rib. Then we will continue from the 5th rib anteriorly to the mid-clavicular line to reach the 6th rib. So this is the oblique fissure of the lung. To draw the horizontal fissure, as we know, horizontal fissure is only located on the right lung. It is absent on the left lung. Then to draw the horizontal fissure, we start from the right side of the sternum, as horizontal fissure is located only on the right of the lung. So we start from the 4th rib from right side of the sternum. We draw a straight line again to reach the mid-axillary line at a 5th rib. So this is the horizontal fissure of the lung. So above the oblique fissure and horizontal fissure is the upper lobe of the lung, and in between the horizontal fissure and the lower margin of the oblique fissure is the middle lobe of the lung, and below the oblique fissure is the lower lobe of the lung. So we have demarcated the right side of the lung. So what is the lower border of the lung then? What is the lower border of the lung? This is the lower border of the lung. Lower border, the lower margin of the lung at anteriorly in the mid-axillary line, it lies at the rib 6. In mid-axillary line, it lies at the rib 8, and posteriorly, it lies at the rib 10. So this is the rule 6, 8, and 10. In the mid-clavicular line, it is 6th rib. In the mid-axillary line, it is 8th rib, and posteriorly, it is the 10th rib. So it is easy to identify the lower border of the lung, which is anteriorly in the mid-axillary line. It is the 6th rib. Mid-clavicular line, it is 6th rib, mid-axillary 8, and posteriorly around the scapula, it is the 10th rib. So we have demarcated the right side of the lung. Same, the left side of the lung only has the oblique fissure, which will start from the T2 vertebra and reach the mid-axillary line at the 5th rib and anteriorly at the 6th rib. And same, the lower border of the lung will start from 6, 8, and 10 vertebra. 6, 8, and 10 vertebra, as it only has oblique fissure. So what is important to know here, that why we are demarcating the lung field? Because various pathology involve various part of the lung. Say for tuberculosis, it has a specific preference for a particular lobe of the lung because it requires higher oxygen concentration to grow. So mostly reactivation tuberculosis preferably occur in the right upper lobe of the lung, which has higher oxygen concentration. So various pneumonias, we will discuss it later, that various infection has a specific lobe to occur, and based on the lobe involvement, we can identify the causative organism. So it is important to know the examining anatomy, and for auscultation, percussion, palpation, all this we have to know the examining anatomy, correctly identify which lung is pathological or which lobe of the lung is involved, particularly to identify the causative organism. So it is easy to identify the different lobes of the lung by demarcating the surface anatomy of the lung. So there are oblique fissures both sides, on the right side and the left side. The right side contain only horizontal fissure. Horizontal fissure is absent on the left side. Oblique fissure we start demarcating from the T2 spinous process. We go posteriorly to reach the mid-axillary line at the 5th rib and anteriorly at the 6th rib. And the horizontal fissure starts from anteriorly from the 4th rib, right side of the sternum, to reach the mid-axillary line at the 5th rib. It completes the horizontal fissure, and the upper lobe is above the horizontal fissure and oblique fissure. The middle lobe is in between the horizontal fissure and oblique fissure, and below the oblique fissure is the lower lobe of the lung. So this is the surface anatomy of the lung, and the lower border of the lung anteriorly in mid-clavicular line is the 6th rib, in mid-axillary line it is the 8th rib, and posteriorly it is the 10th rib. As we know that pleura is slightly lower than the lung. As suppose this is the lung field, this is the lung. So pleura will be slightly lower, the parietal pleura will be slightly lower than the lung border. So what is the surface marking of pleura then? It is just 2 number more than the lung. So anteriorly in mid-clavicular line, the lung ends at the 6th rib. So pleura will end at the 8th rib. And in mid-axillary line, the lung ends at the 8th rib. So pleura will end at the 10th rib. and posteriorly the lung ends at the 10th rib, so pleura will end at the 12th rib. So 8, 10, 12. So 8, 10, 12th rib is the surface marking of the pleura, and 6, 8, 10 is the surface marking of the lung. So it is important to identify the different lobes of the lung by surface marking to identify which pathology is present in which lobe of the lung. So why do we demarcate the various lobes of the lung? To identify the specific pathology involving the lung. So suppose you are getting a crepitations in a particular lung field, then you have to identify which lobe is involved. Suppose you are getting a coarse crepitation in particular lung field, which means the patient might be having pneumonia. So you have to identify which lobe is involved or which lobe is consolidated, which lobe has occurred consolidation. So it is important to demarcate the various lung fields. So anteriorly, as I told you, anteriorly on the right side is the upper lobe and the middle lobe. You can see here anteriorly on the right side is the upper lobe and the middle lobe. You cannot auscultate or do any examination finding for lower lobe anteriorly on the right side. And in mid-axillary line, you can get the upper lobe, the lower lobe only. You can get the upper lobe and the lower lobe only, and sometimes little bit of middle lobe in the mid-axillary line. Posteriorly, you can get only the upper lobe and the middle lobe. So we can say that on the right side anteriorly we get the upper lobe and the middle lobe, and in mid-axillary line we can examine for upper lobe, middle lobe as well as lower lobe. Posteriorly around the scapula we can examine for upper lobe and the lower lobe of the lung. Similarly, on the left side, anteriorly we can examine only for the upper lobe of the lung, because the lower lobe of the lung is in the mid-axillary line. On the left side we have heart, so it's difficult to examine the lower of the lung anteriorly. So in mid-axillary line, we can examine for the upper lobe of the lung and the lower lobe of the lung. As left side we do not have middle lobe. And similarly, posteriorly, we can examine for the upper lobe and the lower lobe of the lung, So it is important to demarcate the various lobe of the lung to identify the specific pathology involving the lung. So suppose you are getting a close capitations in the middle of the lung, suggestive of consolidation of the middle lobe of the lung. Similarly, when we are hearing for the fine crepitations, when you are suspecting a patient to be a case of heart failure, then you will look at basal crepitations, that is the lower side of the lung usually have crepitations, or the fine basal crepitations is heard on the lower lobe of the lung. Then you have to specifically examine the lower lobe of the lung, which is in the mid-axillary line, and posteriorly. You don't have to examine anteriorly on the upper lobe or on the upper side of the chest anteriorly, but you have to examine on the lower side of the chest posteriorly and in the mid-axillary line to hear for the fine basal crepitations in a patient of heart failure. So this is the clinical significance for the examining anatomy of the respiratory system.